All right, Joseph, is all working all right?
Looks good.
Wonderful. Thank you. Good afternoon, everybody. I'm excited to be here. I really am excited to have the opportunity to talk about this subject. It's one that, has impacted a lot of people. I would guess that, between myself and, each one of us here, that we've had, substance abuse, alcohol abuse, addiction, something of that nature, either impact us on a personal level or somebody very close to us, a friend or family member. So I'm excited for the opportunity to talk about this. On that note, this is obviously a very complex disease, addiction in general. So what I'll be focusing on today is what, my field, which is the physiology. So what actually is happening in the brain physically, and focusing also on the I think we have a couple people that still need to mute their microphones, but focusing on the the changes in the brain, and then also focusing on what medications we use to treat those different disorders. Joseph, does it look like everything's working on your end there?
It does. Yeah, it looks like everything's working on my end here.
Okay, sorry, my computer's being a little finicky here. So
okay, you look great.
All right, I'm going to jump to sharing my screen here. Okay, there we go. Okay, so just a little background about myself, for those of you that maybe weren't with us last time. So I'm a pharmacist. I work here at Provo Canyon Behavioral Hospital, and I absolutely love it. I mean, we've got just a phenomenal team here. I feel grateful to be able to work here, and I have developed a real passion for this type of medicine, really helping people struggling with different mental health challenges and substance abuse. We're in the process of expanding our chemical dependency treatment and substance abuse treatment units and facilities here. I'm really excited about that. We've got a great team of psychiatrists and medical docs that we work with. And when we all come together with our awesome team of therapists and social workers as well, it's amazing what can be done for the patients. So I did my bachelor's degree here in Utah. I did one in biology, and then moved up to Idaho where I did my PharmD. And then here I did a little bit additional training, kind of like a fellowship, and then became board certified in psychiatric pharmacy, which includes substance abuse. So, okay, so for today's discussion, we'll get right into it now. We're going to first go over alcohol withdrawal syndrome, so the pathophysiology, then the major symptoms and dangerous complications that can come from alcohol withdrawal syndrome, and then the medications we use to try to treat people that are acutely suffering from alcohol withdrawal syndrome, as well as medications that can be used long-term to help people maintain remission and stay in remission. And then we're going to move on to the acute withdrawal from opioids. So we'll talk about the pathophysiology there. I want to talk about a whole bunch of the opioids that are out there, both prescription and ones that are on the street. There's even one that's kind of an over-the-counter weird gray area you can pick up at the gas station, that kind of thing. And this is obvious. I mean, I don't know if you guys notice them. I see billboards all over. This is a big issue here in Utah and really anywhere. So we'll talk about what we're seeing that way, talk about the symptoms, and then medications that can be used to treat the withdrawals, both short-term in the acute setting, which is what we do here, and then long-term as well. And then lastly, I want to talk about adjunctive medications that we can use in both of these disorders. So that means add-on medications. Sometimes when people are withdrawing or detoxing from either one of these, it can be pretty severe. So there's a whole slew of medications we use, and that can be used outpatient as well, that help to relieve the symptoms of withdrawals. And then we have the staple medications, which we'll talk about too, that actually help keep the withdrawal safe. So, and like Joseph said, if you've got questions, throw them in the chat, or I'll stop periodically, and we can just, I'd rather address the things that are more pertinent and the subjects that are more pertinent to you guys than get through every little bit of the slides. So just let me know if anything comes up. Some of the questions I'll have answers to, some of them I may not, and I'll try to find those for you. So the first thing to address here is the difference between tolerance, dependence, and addiction. I know in the population, kind of as a general rule, these get lumped together, it seems like. but they're very different things, especially when we're talking about them with medications and substances. So tolerance is when a person that's using a medication, all of the, they start to require a higher dose to achieve the same therapeutic response. So this can occur with drugs of abuse like opioids. It can definitely occur with alcohol. It can also occur with all sorts of other medications that we have, certain blood pressure medications and others. So that's tolerance. That in and of itself isn't necessarily a bad or a dangerous or scary thing. Dependence is the second thing. Dependence is when a person is experiencing physical or psychological withdrawal symptoms after abruptly stopping a medication or a drug or a substance. So once again, this can happen with drugs of abuse, but it can also happen, like I said, certain blood pressure meds and other medications. So we have a blood pressure medication called metoprolol, and it slows down the heart just a little bit. It reduces blood pressure. It helps prevent future heart attacks, MIs, that kind of thing. And once your body gets used to it, if you come right off of it, you will have physical withdrawals, not anything like what we're used to seeing with like the way we think of withdrawals with like an opioid, but your body itself will react. And I shouldn't say you will have withdrawals. I should say you could have withdrawals where the blood pressure in the heart will actually rebound and go up just a little bit stronger than it even was before the med. So once again, in and of itself, not necessarily a scary or dangerous thing, just has to be watched. Addiction is the third. Now, addiction oftentimes includes both tolerance and dependence. But according to the Mayo Clinic, there's varying definitions, but a disease that affects a person's brain and behavior and leads to an inability to control the use of a legal or an illegal drug or medicine, or really any substance there. So addiction is once we've crossed the line and no longer have the ability or feel the ability to control what we're doing. Oftentimes it's a harmful behavior. We know it's hurting ourselves or other people, but we continue to seek that drug or that medication or whatever it is to satisfy the cravings or the withdrawals. So, okay. So as we look at alcohol withdrawal syndrome, this is kind of the pathophysiology of it. So what the body's trying to do is maintain homeostasis. Let me switch something on my computer here. Okay, maintain homeostasis. So I don't know if you guys use that word a lot, but what homeostasis means is the body's tendency or desire to get things back to kind of a general equal balanced state that is the best for survival. So there's a lot of things that can throw our body out of homeostasis, and our body's always going to be fighting to get back to that. And one of the things is alcohol. So alcohol use throws our body out of homeostasis. So our body physically, the neurons in our brain make adjustments and changes to deal with that. So right here on the screen on my little graphic, we can see this little neurotransmitter called GABA. So GABA is a neurotransmitter that causes us to calm down. So psychologically, you feel calm, you feel relaxed. Physiologically and physically, it slows the heart rate, it slows blood or lowers blood pressure usually, and it just causes things to slow down. Overall, it's a CNS or central nervous system depressant. So what occurs with alcohol use is alcohol gets right in here in between the two neurons, a signaling area called the synapse. And it's going to act on this GABA receptor. So it's not GABA itself, but it mimics what GABA does. And so what that leads to is the effects that people feel from alcohol. So CNS or central nervous system depression, everything slows down. And physically, the heart rate goes down oftentimes, blood pressure, and things start to slow down. So if somebody has a drink and that occurs once, body's not likely to make any long-term changes. But if we're drinking regularly, what's going to happen is your body senses that homeostasis no longer exists, and it thinks there's too much GABA right here. So it's going to take these receptors right here, the GABA receptors, and it actually downregulates them. So it basically eats them all up. It'll pull them into the cell and it'll destroy them long term. And so that leaves fewer of these GABA receptors on the cell surface to get stimulated, because you've just flooded this, or the person has flooded it with alcohol. And so what happens is all of a sudden, when alcohol is removed, All you have is your endogenous or the regular old GABA that's coming from this neuron, but no more alcohol. The problem is you only have a couple or fewer of these GABA receptors on the cell surface. And so all of a sudden, your body is in a state of excitability. Things are really ramped up. And so it really activates what's called our sympathetic nervous system. And that's our fight or flight. So the parasympathetic nervous system, as I'm sure you guys know, is the rest and relax kind of nervous system and digest. And then the parasympathetic is that fight or flight. So it's what gets stimulated if we run into a bear while we're camping or a dangerous situation. But it puts that into overdrive because you don't have the regular levels of GABA receptors to help mitigate that and bring it down. Your body's kind of fighting against that alcohol that it was put in, that had been in the body. So that's what leads to this major overactivity of the sympathetic nervous system and the symptoms that we see from alcohol withdrawal. And in fact, here on this slide, these are the symptoms. So the minor symptoms, and you'll see I put that in quotes. The reason I did that is they're considered minor from a medical standpoint, but to the person experiencing these, oftentimes they're very anything but minor. So restlessness, which can become severe, anxiety, which depending on the person's pre-existing conditions, the person going through alcohol withdrawal, that can be bad. It can be really bad, can lead to panic attacks and that kind of thing. Some do okay with it. Agitation, that can be mild, moderate, or severe. Insomnia, which then just builds on the problems they're already having because they don't get good sleep. Tremors, which is a shaking that we see during alcohol withdrawals. Sweating, palpitations, which is the heart. You can feel your heart, pounding in your chest, or you feel your heart racing. And that's because your heart actually is doing exactly that. Your body's kind of confused and it's been upregulating, pushing so hard for so long against that alcohol that once it's gone, it keeps pushing for a little while until it can make adjustments. Headaches, and then those cravings for more alcohol. So some people experience these symptoms for a couple of days and it goes away. It very much depends on the person, their history, pre-existing conditions, depends on how much they've been drinking and how long. And even that, there's no set amount of if you drink this much, this will happen. It very much depends on the person. And then some of them have these minor symptoms that progress to more severe symptoms. That usually happens within about 12 to 48 hours. So just this little note here, it's imperative that if you yourself or you've got a patient that's concerned about alcohol withdrawals, that they're evaluated by a qualified healthcare professional, because some of these other things that I'm about to talk about here are harder for patients and caregivers to see, and they rely a lot on taking vitals like blood pressure, heart rate, running certain labs, and they help to tip us off when something more severe is happening. So when we look at the severe withdrawal symptoms, we've got alcohol hallucinosis, which is hallucinations, but it's caused by the alcohol withdrawal. We've got delirium, which can be super dangerous, seizures, which can prove fatal in this condition, severe hypertension or high blood pressure. The delirium, it's called DTs, delirium tremens, and we'll go over that just a little bit. It can also be fatal. And then we have Wernicke's encephalopathy, which we'll discuss in a little bit, and that can be fatal too. So when we look at alcohol.
Can I ask a quick question, actually?
Yeah, you bet.
So I have a client who just actually came out of a detox program for alcoholism. She was there for about a month, and she's just experiencing like severe anxiety, but she's been out of the program, I think, for like 2 months now. And she's been doing okay with her treatment plan, but like, would that be something that maybe considering that she might need to have a little bit more evaluation? Because I've been trying to figure out the anxiety aspect, and she does have a medical provider who's helping with like her medications, but yeah, I've just been trying to figure out the anxiety, and this is going to sound like it could be part of it. So I guess my question is, how long can these symptoms last after going through some sort of alcohol detox, and when should we be recommending that they maybe get more professional help? Does that make sense?
It does. Yeah, that's a great question. So the answer is it really does depend, but it depends on the symptoms and the person's pre-existing conditions. But things like the anxiety, insomnia, restlessness, agitation, they can go on for quite a while. It's called post-acute withdrawal syndrome, and not everybody gets it. It's kind of a little bit of a less defined syndrome, but it's some of these symptoms that are hanging around even after. And so, yeah, I mean, if it were me, if somebody's experiencing really severe or pretty significant anxiety, I would think they need some follow-up for sure. Sometimes just the alcohol itself, the alcohol abuse and then withdrawals can kind of induce a state of anxiety in and of itself. And we really are, with alcohol, we're messing with our our neurophysiology, our neurons. We're restructuring the way our brain's working when we use that much alcohol. And so what comes after could be something different than they've had. And it could be an exacerbation of a pre-existing condition. And so if it's something like anxiety, that's not like an urgent get to the ER situation, which something like, say, delirium or a seizure or really high blood pressure would be, but it's something that, in my opinion, would need to be followed up on and treated for sure. But they can go on. Same with opioids, they can go on. It's tough to distinguish, though, too. This is why it's kind of a gray area, the diagnosis of post-acute withdrawal syndrome, in that it's hard to tell what is just happening with the patient. Maybe they had anxiety before versus, is this actually a fact that because of the drug use or alcohol abuse before. But there's many that believe that there's a whole lot of the neurochemistry in the brain that absolutely does not basically fix itself or return back to normal for upwards of a year or more. So when we do medical withdrawal, like chemical dependency and medication assisted treatment here, we are basically getting them through the dangerous parts of the withdrawal, but we are not going to get them through all of it. And so there'll be a lot of follow-up after. Does that kind of answer the question?
Yes, that does. Thank you so much.
Yeah, absolutely.
Hey, Dan, we have one more question in the chat.
Yeah.
Alice is asking what you do for the hallucinosis and delirium.
Okay, perfect. So I'm actually going to get to that here in just a slide or two. So we'll dig right into that. I will say those are medical emergencies. So we need to have somebody in a facility like ours or in an ER if there's any of that going on with alcohol withdrawal. And so on that note, here is kind of a timeline. This actually proves really important in the medical world when we're looking at this. But this is a timeline of when these symptoms usually happen. And this is in the acute stage of withdrawal. So somebody just mentioned the hallucinations and how you treat that. One thing I'll point out, alcohol hallucinosis, so some of these hallucinations can occur between the 12 and 48 hour mark. But if they occur after the 48-hour mark, we start to think of this delirium tremens, which is an absolutely life-threatening condition. And it takes more than just hallucinations to diagnose that. But anytime there's hallucinations, we start to think, are we in this realm? And we're at least in this realm, which is considered severe withdrawal. And yeah, those minor withdrawal symptoms that happen a little bit earlier on there, once again, they're mild in the grand scheme of things, but they're not mild to the people going through them in most cases. So, okay, so the hallucinations we'll get to right down here, and that's a great question. Like I said, the first one I wanted to hit here is called Wernicke's encephalopathy. So the delirium, even some of the hallucinations could be caused by this, but you need medical evaluation. This one's kind of interesting because the way it's treated and prevented is vitamin B1. And so you think sometimes maybe in a hospital or an acute setting, vitamins, here or there, whatever, we'll get them when we can. This is actually probably one of the top 2 medications that we use in this hospital as far as medical emergencies and saving lives. So when somebody comes in with alcohol use disorder and they're in withdrawal, a couple things have happened. Number one, oftentimes people in that situation have not been eating a good diet. They've been supplementing a lot of their calories with alcohol. So they could be vitamin deficient just in and of that in and of itself can cause it. But also the alcohol messes with their GI tract and their ability to absorb vitamins, and particularly vitamin B1. And so what happens is when the alcohol is removed and everything's so upregulated in the central nervous system. Neurons are firing like crazy, blood pressure's up, your body's trying to slow down. In your brain, you burn off an enormous amount of energy or glucose. But vitamin B1 is, you have to have that to burn off glucose. And I think we've all heard a little bit about that, how the different vitamin Bs can give us energy or at least help with energy metabolism. So what happens in these patients, and this is not terribly uncommon, is in acute severe alcohol withdrawal, is they burn off so much glucose that they use up the little bit of vitamin B1 they have in their brain, in their central nervous system. And then the glucose just sits there, water follows it because of osmosis, and you get brain swelling. And that can start to lead to delirium, that can lead to seizures, that can lead to hallucinations, just a whole slew of things. So everybody that comes into our hospital that has any history of alcohol abuse, if we're treating that, they automatically get a shot, an injection of vitamin B1, and then they get a high dose every day of that vitamin B1 to help prevent it. Next one here is the withdrawal seizure. So GABA, which is that neurotransmitter, and then the receptor, the GABA receptor that alcohol stimulates. Alcohol mimics that GABA. That's an important part of the seizure regulation in the brain. So a lot of the drugs we use to treat seizures for people who have a seizure disorder, they activate this GABA receptor. So all of a sudden, we don't have any, when alcohol is removed, we don't have the activation of that receptor, and so seizures can occur. And seizures and alcohol withdrawals can be life-threatening. They're a dangerous thing. So, okay, and then down here to the delirium tremens, DT. So it's defined as a constellation of hallucinations, disorientation, tachycardia, which is the elevated heart rate, hypertension, which is the elevated blood pressure, hyperthermia, so like a fever, high body temperature, agitation, and sweating in the setting of acute reduction or abstinence from alcohol. And that is very life-threatening. I think, trying to get to that question here, okay, so that I've got it here on this slide. So to treat it, and I guess I already hit this, but Wernicke's encephalopathy, you prevent and treat it by using thiamine, which is vitamin B1. So as far as the delirium and the withdrawal seizures and the hallucinations, I didn't list it right here, but they're all treated with the same drug class here. And we use as the primary go-to benzodiazepines. So those are like diazepam, which is Valium, brand name's Valium, lorazepam, you may know as Ativan, chlordiazepoxide, which is known as Librium. So they can both prevent and treat the hallucinations, the delirium, and really all of the above for alcohol withdrawal. And this has been kind of a complex issue off and on here at the hospital, because when we look at these medications and we have nurses or new providers administering these medications, we're used to seeing doses. So say like lorazepam, 1 milligram, that's a pretty hefty dose for most of us. If we haven't been taking benzodiazepines or chronic alcohol use, that's enough to knock us out for quite a while, at least make us super, super tired and kind of lethargic. But we will get situations where patients in the ER even are using upwards of 40 or 50 milligrams of lorazepam just to keep the symptoms down enough to function. And so in an inpatient setting like this, we'll do really high doses of these medications to try to keep all of these symptoms down and to keep the hallucinations and those types of things from happening. So there's a lot of other medications that will mask or relieve some of these symptoms, but really it's only benzodiazepines that there's a few others like phenobarbital, but it's primarily benzodiazepines that treat and prevent the serious issues associated with alcohol withdrawal. And as far as the question more specifically on the hallucinosis, so our go-to number one is going to be these benzodiazepines in an inpatient setting, and that's going to not specifically attack the hallucinations, but it's going to bring down all of the alcohol withdrawal and hopefully eliminate those hallucinations. If we're in a situation where we've used enough of these benzodiazepines and you've got the blood pressure down, the other symptoms are down, you have a psychiatrist or a skilled medical doc that's looked at the patient and says, hey, look, everything's under control here, but they're still having some hallucinations, alcohol hallucinosis, we don't have delirium tremens or anything else going on here, then we can add on an antipsychotic. So there is, controversy in the field as to which one is the best, because all of the antipsychotics can cause, well, I shouldn't say can cause, but increase the risk of a seizure just a little bit. And these patients are already at risk of seizures. So, there's some people that'll use Haldol or haloperidol. There's some that'll use olanzapine. There's some that'll use quetiapine. That's probably, I think, the most used one, which is brand name on that, Seroquel. But once again, what we try to do is treat it with the benzodiazepines and not use one of those additional unless we have to, because they bring their own side effects and other issues too. So one thing that could happen too, I should bring up, is you could have a patient with alcohol hallucinosis and you could treat them with an antipsychotic and make their hallucinations go away, while everything else just ramped up and they, their brain swelled and they ended up in a really bad position. So once again, these are kind of the mainstay on that. So Joseph, any other questions in the chat right now?
It looks like Alice is asking, at that point, they're in the hospital. She's asking, I think she's referring to that last part that you were talking about, when the brain starts swelling and things like that.
Yeah, they are. And as far as the hospital, like you got the, a med surg kind of acute care hospital like that, the big facilities, or you've got an inpatient medical detox center, kind of like we are here. And we try to walk that fine line. If they are all the way to where their brain's swelling, we're getting them to the ER. They need all sorts of other care, and they need IV treatments, these medications and the thiamine IV. But our docs, they get really good and are good at kind of seeing and looking at the patient and deciding, are they to the point to where we can control this with benzodiazepines, or has it already kind of crossed that level? Anytime it's to DT, delirium tremens, it's a medical emergency. And there's very, very few cases we would even keep somebody here with DT. They're likely going to end up in the ER and then a ICU. So. Okay, so we kind of ran through these on the other slide, which is just the minor to moderate withdrawal symptoms. Once again, the benzodiazepines, when we use tapers, so we start at a high dose and come down, they reduce all of these symptoms and help to prevent and treat the dangerous side effects. So then in our facility, and in any facility really, and they can even do some of this outpatient, we use these, what we call our detox PRNs. So PRN in the nerdy pharmacy world means as needed. And so there are these detox medications that treat each of these symptoms that may come up. But we do have to be a little bit careful with that. We want to make sure we're treating with benzodiazepines, the underlying alcohol withdrawal, and then kind of fine tuning with those. And we're going to dig into those individually a little bit more, but we'll do that after the opioid section, because we use them in opioid detox as well.
We have a quick question here in the chat. Katie's asking, do you see a lot of patients that have low sodium related to alcoholism?
That have, that have what?
Low sodium.
I don't know that we do here. In a like an ER ICU setting, those electrolytes are going to be more likely to be out of balance. We don't see a ton of low sodium here, but when you are drinking that much alcohol, your body is fighting constantly to keep electrolytes, so sodium, potassium, magnesium in balance. So, I mean, you could throw that out of balance for sure. We don't see a ton of it here, but it's definitely possible. We see a little bit more of the low potassium, I would say, but part of that is, I think, due to where we live, just in America in general, we have a high sodium diet. And so a lot of us are getting so much sodium anyway, the body does okay with that, but it definitely could be an issue for sure. So good question. And then just quick slide here on the benzos in general. So we're talking about them in the context of alcohol withdrawal right now. And these are life-saving. They're absolutely essential, but they in and of themselves, kind of like alcohol, are can be addictive, can be dangerous medications. So you have to be careful with these. So I've listed the names up top there. So we've got clonazepam, which is Klonopin. And then we mentioned the chlordiazepoxide, which is Librium. Temazepam, which is primarily used for sleep, and that's Restoril. Lorazepam, which is Ativan. Diazepam, which is Valium. And then Alprazolam, which is Xanax. And when you look at these, all of them can lead to dependence. All of them can lead to tolerance. If you take them regularly, they will lead to dependence. They just will if they're taken consistently. And then we're back in a position just like alcohol withdrawal, where you can have life-threatening withdrawals from benzodiazepines. So very similar symptomology and pathophysiology as the alcohol withdrawal. So we limit the use here at the hospital of these to primarily a taper, where a patient will do about a 3 to 7 day taper, where we start on kind of a higher dose and move them down, and then somewhere between day 3 and 7, depending on which taper we use, they're done, and they're done with the benzos. And then going along with the question that was asked earlier on, I think it was Brooke, if at this point we've discharged the patient, they still have some residual symptoms, say the anxiety, that's when we look at treating with something like an SSRI, Buspirone, or a normal regular psych medication. If we treated with this, if we treated a patient with Ativan, their anxiety would likely go away pretty quick afterwards. Problem is we're just creating a whole nother problem by using that medication regularly in place of the alcohol. So you just want to be careful with these. We're going to talk about opioids, so I think it's important to note these become very dangerous when combined with opioids, because they have somewhat of a synergistic effect on respiratory depression, slowing the breathing, and sedation. So you want to be careful with that. I think that's about it on benzos. I will point out many people outpatient use these safely and responsibly, and they can be good, but you do have to be careful with these. There are some facilities and people that won't use alprazolam, which is Xanax, just because it tends to cause the most euphoria, be worth the most on the street. But like I said, there's plenty of people that use it responsibly outpatient. General consensus and guidelines are when treating anxiety that we're not using these benzodiazepines more than, maybe once or at the most twice a week, unless it's right at the beginning where we're trying to get something under control, anxiety under control, while an SSRI is kicking in or something like that. So, okay. So just some specifics here on the benzodiazepines, and I don't know, we won't spend too much time on this, but when we look at them, this diazepam, which is Valium, it works really quick. So do these other two, lorazepam and chlordiazepoxide. And then we look at half-life, and this matters in substance abuse big time, because the shorter the half-life of a medication, the more likely you are to have withdrawals from it. So heroin's probably the go-to example of that. Heroin's got a short half-life, but its onset of action is super fast. So it'll flood the brain, go right across the blood-brain barrier, saturate the receptors, and just cause that major euphoric high. And then as it wears off, that's when you get the withdrawal. So we try wherever possible, when patients are going through withdrawals, to use a longer acting medication, like say diazepam, which is Valium, or chlordiazepoxide. If we're using something like this lorazepam, we're going to have to use a lot more of it more frequently, because they'll just end up with withdrawals. So same strategy we use if somebody has some sort of dependence or addiction issue with benzodiazepines, try to switch them to a longer acting one and slowly taper them off. So.
Dan, Josh has a question. I believe this is in reference to that last slide with the opioids, but he's asking, how often does one have to take to become dependent on average? Yeah,
great question. And I wish I had an answer for that. So as a pharmacist, left brain person, I'm always looking for hey, well, what's the number? How many drinks do they have to drink a day? So I pick this benzo and this taper, but it's actually more of an art. And so what we generally say is 2 weeks of regular use, but that can vary quite significantly. And then if you've been using a benzo or something for 2 weeks, a strategy you take, or for longer, inpatient, detox isn't usually needed if you're using it responsibly the way that it's prescribed. You just work with the prescriber and you say, hey, I'm ready to start tapering off of this. And they'll do a very slow taper. And this is not one you want to stop cold turkey. a slow taper and kind of just see symptoms as they come out there. And I mean, there's a reason somebody was using the benzo, right? So if it's anxiety, it's going to come back. It's going to rear its ugly head. So we've got to treat that with something new, an SSRI or psychotherapy, whatever it is. But tapering off of these slow and usually replacing it with either another medication that's a safer long-term medication or therapy of some sort to help treat the underlying problem there.
Katie's asking if you said that bupropion is used, and I believe that was probably in reference to your very last slide that you had up.
I might, if I said bupropion, I misspoke. So I did mention buspirone as one of the meds that can be used to treat anxiety. Bupropion is definitely, so if I said that, I apologize. Bupropion's not used in alcohol withdrawal syndrome because it can predispose somebody to having seizures. Doesn't usually cause seizures in people, but in somebody who's already in a sensitive situation like this, kind of teetering on the edge, we try to avoid it where possible. So buspirone can be used for anxiety, and that's separate from the alcohol withdrawal, but bupropion, that one's generally avoided in these circumstances. Okay, so how is it measured? In some of the questions were along these lines. It really takes a qualified clinician. So what the kind of the expert consensus is that this CWA-AR is used, and it measures these things right here, and it gives them an actual numerical objective score, so that we can say, so like in our facility, we'll say, if you have a CWA greater than 8 or 10 or whatever it may be, we want you, the nurses, to treat with a benzodiazepine or something like that. Even with this, there's variability, but if you just had no system that would put a number, an objective number to these symptoms, the variability from clinician to clinician would be so huge. It's already big because there's, as you guys have probably seen, there's a variety of different approaches to treating these types of challenges, these types of addictions. Some people say make it as smooth and as painless and easy as possible, and that will help them not, transition to a good spot, not go back on the medication. You have other clinicians that say, hey, this should be a little bit rough, because if they don't feel any pain, any discomfort, then they're just going to say, I'll just detox again later. So, I mean, there's so many different ways to think about this, that this helps kind of professional way of objectifying it, or making an objective standard for it. So okay, so with that, I'm going to jump into the opioid withdrawals. So these are lists. This isn't all of the opioids, but this is a list of a lot of them. So the ones I've started here top left are the ones that can be legally prescribed, but they can also be abused and misused, and you can find these being abused on the street illegally as well. And I mean, there was more than once at my last job, sadly, where I watched somebody come in and fill one of these just to walk out to the parking lot and have a shady exchange with somebody involving cash and the medication I just filled going into somebody else's hands. So it's a tough thing to try to track and keep an eye on. But we've got tramadol, which that one's kind of gone back and forth, but it does have opioid action. It can cause addiction and withdrawals. Generally speaking, not to the level of these others, but it depends on the person. This medication is transformed by your liver into a morphine-like substance. But what we found over the years is when we look at people's genetics, there are some people that are rapid metabolizers. It means they really chop this up fast in their liver, and they produce a whole bunch of morphine-like substance. So you can get people that take tramadol, feel almost no opioid type reaction. You can get other people that take it and feel it as strong as they would on some of these others. So one to be aware of there. And then we've got the hydrocodone, always has Tylenol with it, Norco, Vicodin, brand names there. The Tylenol in these combinations, it does help, but its primary purpose is to prevent and reduce abuse. Because if you have hydrocodone alone, you could take a handful of pills, somebody that's abusing it. But if they do that with the Tylenol in it, then they're going to end up in a really bad spot, damaging their liver. So part of the reason that Tylenol's in these is to help prevent abuse. And we've got the oxycodone, we've got buprenorphine, which is Subutex, and buprenorphine with naloxone, which is Suboxone, which we'll talk about those a little bit more in just a minute. Methadone, which you guys have probably heard of and seen used. The three that are most commonly used for opioid medication-assisted treatment in opioid use disorder are going to be this buprenorphine, and then buprenorphine with naloxone and methadone. Then we got hydromorphone, and then fentanyl, which we've heard a lot about in the news lately. Brand name on that, the patch is Duragesic. Fentanyl becomes a complicated one because it is super useful. I mean, borderline essential in the medical community. It's used by anesthesiologists. It's used for people in cancer with severe cancer pain. But as soon as this started hitting the streets and people are lacing these other, or heroin with it and these other medications, it's so potent, just a little bit of it, that it can become fatal quick. So then some of the always illegal ones are class 1. So you've got heroin, and then we've got this unregulated one, kratom. So this one can be picked up at gas stations. I had my son bring it up to me a while ago. It has both stimulant and opioid properties. It comes from, it's a natural product derived from a plant. And so it's currently unregulated federally. And the FDA's put out a number of warnings. And it was just, a month or two ago that I went out to see a patient on one of our units who we weren't quite sure what to do, like what taper to put her on, because this is what she had been abusing and was starting to enter into some pretty significant withdrawals. And this is, you don't know how much of the plant extract you're getting. It's really tough to tell, but it is not a harmless supplement. It has real biological activity, and it's a dangerous one. So, I mean, my guess is in a matter of time that'll be pulled from the market, but it takes time for the FDA to gather information and make a move like that. So, okay, not going to spend time on this one. This is essentially the same thing, the same concept, I should say, as the alcohol withdrawal and physiology. Different receptors. They're working on the opioid receptors, but the concept and the principle of overdoing it and then your body adjusting is the same. So, Joseph, any questions that I should address right now?
Let's see. It looks like Chantal is asking, she's saying people talk about detoxing from opioids using kratom. Is that how you pronounce it?
Yeah.
Kratom?
So,
yeah, go ahead.
Question was about using kratom to detox from opioids.
It looks like she was just making a comment that people talk about detoxing from opioids using kratom.
Yeah, so super dangerous strategy, right? Kratom's unregulated. We have no idea how much you're getting or how much you're not getting. And so if you're trying to detox from an opioid and you add in some kratom, it can relieve symptoms, but if you end up with more, then you're doing the opposite of detoxing. If you end up with way less, you can throw yourself into really nasty withdrawals. So it's recommended that we don't do that, but you're right on. People do talk about that, and on the street, it is used that way. So if people can't get more of their opioid, it could potentially help reduce the symptoms, but it also has stimulant properties. And so at lower doses, it's a messy drug. So
also, I'm just going to drop
Dan, can I ask? Oh, sorry.
Oh, go ahead.
I was just going to ask another question about opioids, because I'm in a tricky situation trying to help someone right now who has severe problems, like back problems, where they've had multiple surgeries and whatnot, and their doctor has long-term prescribed them Percocet, and where they've been on this for now, I think, close to a decade or something like that. And they're presenting in therapy with actual like addiction problems where it's affecting the family. There's definite misuse of the medication as well, where they at times are taking all of their medication for the first 2 weeks that's supposed to last them a month, and then going through withdrawal symptoms for the last 2 weeks of the month before they can refill their medication. How do you even treat something like that? Because it's a necessity for them to treat their pain. Like doctors, surgeons have all like said like they need this for life, but to me, as like in the psychology field, that just seems like a very tricky situation. Then at like what cost? But then they don't have much of a life either. They would pretty much be bedridden if they don't have anything to manage that pain. And they said nothing else has worked besides the Percocet and that their doctors actually said this is the only thing that's going to work at this time. So anyway, do you know of anything else to help in those situations where somebody is needing that type of pain management, but that they are also having addiction symptoms too?
Yeah, so that's a complicated one, but it's not uncommon. And so we've definitely crossed the threshold of addiction at that point. People can be on these long term. I remember my dad, his twin sister had some pretty significant addiction issues. And so when he got diagnosed with cancer, which was in his spine, he had to go on some of these. And he said, Dan, I'm worried about addiction. And I said, well, you'll become dependent, but you don't have to become addicted. So people can be on these long term and they'll have dependence, meaning if they couldn't get their refill, they'll have withdrawals. But this is clearly crossed into the addiction. So there's a couple strategies that number one is you try anything else and everything else, surgery, which has been done in this patient. And then the other thing two of the things that can be done, at least in my experience, is if there's somebody that can manage the medication and give that person their dose, each day and keep the medication locked up. Sometimes that's what it takes. And then, psychotherapy, some sort of therapy, and helping the person understand, like you. And this obviously is way out of my wheelhouse, but helping the person understand, like, you have a real issue with addiction here. You do need the medication, but you're creating a situation where you're not going to be able to have the medication. So you need to relinquish the control enough that, somebody can basically control the medication and give you your dose. And then I'm going to jump right here to this buprenorphine and buprenorphine with naloxone and methadone, because in the situation you just mentioned, these medications are oftentimes used and can potentially be useful, because buprenorphine and methadone both relieve pain. They activate those opioid receptors, but they're a little bit, particularly buprenorphine, that's the one that's more commonly used now. It's a little bit harder to abuse. So it's what's called a partial agonist. So agonism means stimulating the receptor. So buprenorphine only stimulates the receptor to a certain level. So when people try to overuse it, they still can, if they really overuse it, get that euphoria and the high, but it's a lot harder to do. And then methadone is very highly controlled. And so when it gets to the point of a methadone clinic, patients, I talked about controlling the dose of the medication. Patients have to go in daily, and they have to go into the methadone clinic each day, and they have to get their medication. They drink it in liquid form and then they go home, and they can send them home with a dose or two now, but it's a cumbersome thing, but it's the way methadone clinics legally have to be run. Now you can use methadone outside of that, a methadone clinic, if the primary indication is for chronic pain, even if there is some opioid use disorder, but you can't use it outside of the clinic setting unless you've got a primary indication of pain. So that is a tough situation. But like I said, if the patient would relinquish control of the medication to a caregiver that could give them a certain, appropriate dose each day, or there is the possibility of going to a pain / addiction specialist and trying to transition to a buprenorphine or a methadone. So those are all different strategies. And then counseling and consulting patients as much as possible up front that need to be on these long-term about what addiction is, what it looks like, what the early signs and symptoms of abuse, drug abuse can be super helpful too, because I've heard story after story just like that of people that are using them for a legit purpose, but then a couple of things happen. Sometimes they realize I have more energy, I feel whatever, so they take a little bit more, then they run out early, or they take a little bit more one time, then have some withdrawals and have to take more, and it just kind of spirals out of control. So, but yeah, there are some people that simply are going to have it long term. There's just no other way to live life. So those are some of the strategies that can be implemented. But that is a tough situation. So. And then Joseph, did you have something to?
Yeah, I was just going to let everyone know that I dropped the evaluation link in the chat. So if you are hoping for CE credit for this class, go ahead and fill out that evaluation so we can get you the certificate. And if you have an email address, or if you work for IHC, in the past we've had a few issues with the firewall there. So if you're unable to, for some reason, access it from home or a different email address or something, go ahead and shoot me an email. I put that in the chat and I'll put it in again later. Just so that you have that in case you run into technical issues.
Okay, and then just to kind of wrap up this section here, so buprenorphine, which is Subutex, the brand name, and then Suboxone, which is commonly used, which is buprenorphine and naloxone. Naloxone is that Narcan we hear a lot about, but the reason it's combined here, when you take Narcan, naloxone orally, so like in a pill form, none of it's absorbed, almost none of it, so it really has no action in your body. But and that's why all of the kits that are available for rescue naloxone are either nasal spray or injection, because it's got to get right into your blood system that way. So it just helps deter abuse. So if we prescribe somebody Suboxone, which is buprenorphine naloxone outpatient, if they attempted to either melt it down and inject it or crystallize it and snort it, anything like that, it's going to block a lot of that high there. So, and then these are some of the medications we use to help in acute withdrawal. So the question earlier was asked about anxiety. I will point out these, the hydroxyzine and clonidine, these are really more temporary acute use. But if they have residual anxiety, the go-to really is SSRIs and sometimes buspirone, but trying to treat the anxiety that way. And then, yeah, just a few of the others. Diarrhea is very common with opioid withdrawals, nausea, vomiting as well. Insomnia crosses over to both alcohol and opioids. Muscle cramps can be both, but mostly opioids. And then abdominal cramping can be both, but mostly opioids. So restlessness with both as well. So it can be a pretty gnarly, onslaught of symptoms that just knock somebody down and kick them while they're down as this all happens, especially if they've got like pre-existing anxiety or pre-existing, conditions, psychiatric conditions. I mean, it can be really hard. So getting the appropriate help is really important. It can be hard, but with the appropriate help, it's so doable, and success can be found. So I better mention too, so naloxone, there's been a lot of talk about that in the news. It's a mu opioid, so the opioid receptor antagonist, meaning it blocks it. And even fentanyl, it's stronger on the opioid receptor than any of the opioids that are out there. So if we give a patient naloxone, or you give a patient naloxone, these kits can be picked up at the library, pharmacies. They're just trying to get it out. The health department is everywhere. If we give a patient this, it will go in and block. It will knock off almost all the opioids off of the receptors. And it can save a person's life, but do be aware it is also going to throw them into acute withdrawals quick too. So most patients are happy later that their life was saved, but they're not super happy the minute this stuff kicks in and they wake up and feel everything hit at once. So just a couple of things to be aware of with it. It's not real dangerous. Like, if you think somebody has opioid overdose, they generally recommend just use it if you have access to it. If it's some other overdose, it's not going to cause problems, not going to hurt them. So it's relatively safe that way. It does have a short half-life, and some of these opioids have really long half-lives. And so you do need to be careful too. When you give somebody naloxone, like at home or wherever, it is not a case closed. It is get them to the hospital or have an ambulance come. But that can be the initial life-saving step that can be taken. But there are cases where you give naloxone, it's got a relatively short half-life, an hour and a half, and after 6-7 hours it's worn off, and you still have a whole bunch of opioid in the system that then starts to go back and occupy those receptors and do the same thing. So, and then this here is, and this will be in the slides, but this is one of the things the health department has come up with. So this QR code can be scanned, and they will help you find naloxone and help you find resources for it. Like I said, but most pharmacies have it and have some way of getting it. Some of the local libraries do. But if you go to the health department, not only will they provide you through these resources access to naloxone or a way to get it, they will provide you with a whole slew of other resources to help patients that are struggling with this. So, and it can be life-saving. So, and then this is SAMHSA. So there's a national hotline set up for help as well. And you can find that real easily online. You can call them, they'll direct you to help as well. And then just as a last thing, and this is important, and we've even talked specifically about a couple patients today, just a reminder, this CE is just for educational, informational purposes. If you got any real problems, questions, concerns that are acute, you definitely want to get to a doc or get your patient to a healthcare provider that can establish a relationship. A lot of these meds I've mentioned too, we use them based on vital signs and labs that we're getting. And so there's a lot that goes into it. So you just want to make sure that you get to somebody that can help out, and even local urgent care can help out with the initial visit with this kind of stuff. So Joseph, with that, any other questions you see there?
Yeah, it looks like Chantal asked just a couple minutes ago, for people who do MAT, M-A-T, I believe, long-term, are there long-term effects emotionally or physically, like anhedonia type things?
There can be, and so the current recommendation is that the long-term MAT, medication assisted therapy, so that's usually buprenorphine that's used, sometimes methadone. Current recommendation is that be used in patients who are relapsing repeatedly. Outcomes do tend to be better when it's used long-term. But as far as long-term problems, there can be, because we're basically giving a certain dose of opioid that's a harder one to abuse, but a certain dose of opioid long-term or for the rest of their life. But as far as specifics on it, it really depends on the person. And so some people do just fine emotionally and physically. Some have, different issues, anxiety, depression, apathy, whatever it may be. And it's hard to tell if that's coming from the drug or the disease that we're treating. But what you have to do at that point is consider a further taper off of it, or treat with another medication. But there isn't any real solid evidence to say if you use long-term MAT, medication assisted therapy for addiction, that these things are more likely to happen. The only thing we really know is that they are more likely to not relapse if we do that, but then it can be very individually variable at that point.
And Lisa's asking, when we speak about half-life of a drug, what exactly do we mean by half-life?
I appreciate you asking that. So sometimes us pharmacy nerds get into our words and don't explain it real well. So half-life is basically how long the drug lasts in your body, so in your blood system. So when we say half-life, it's the amount of time that it takes for half of the drug to disappear. And so, well, it doesn't disappear, but to be removed from your bloodstream. So it's your liver and your kidney primarily that are cleansing your system of that drug. So when I say something has a short half-life, what I'm getting at there is it gets in your body and then your body gets rid of it pretty quick. Something with a really long half-life, like methadone, is an example of that. It gets in your body, and that can hang around after you've taken your last dose. I mean, it can hang around for weeks in some cases. And so when you look at withdrawals, you tend to have the most withdrawals and the most severe withdrawals if a medication has a short half-life or doesn't last as long in your body, because it's removed from the bloodstream so quick. And Xanax is another example of one that's removed pretty quick, alprazolam. So
Any other questions from anyone still in attendance? I know we kind of ran over a little bit, but this has been a great presentation. Were there any other questions that anyone had before we let Dan go?
all right, thank you all. I appreciate it. Appreciate the interaction, and have a great day.
Thanks, Dan. Appreciate it. And for those of you who would like CE credit for this course, I'll drop the evaluation in the chat one more time if you don't already have it. We're using code SA328. So that's S as in Sam, A as in Apple, 328 as in today's date. And if you run into any issues, please email me. I've already had a couple people tell me that they are, just because of their company's firewall, they're unable to access the evaluation form, and that's okay. I will see about emailing a different email address if you have another one. And if not, I will see how we can figure out a workaround to get you the evaluation. Okay. Okay, so there's the evaluation, the code that you need, SA328, and my email. Again, I will be uploading the class to YouTube. So if you want to check out our YouTube channel, I'll drop a link to that as well in the chat here. And I'll also include that in the email that I sent out with the certificate. And I'm also going to include the slides. I know a couple of people that asked about that as well. So if you want the slides, you will definitely get the slides with the certificate. So yeah, if you have any other questions or anything, anything else for Dan, go ahead and shoot me an email. I know we ran over a little bit and sometimes we don't always get our questions in. If you had a question or something that you wanted some follow-up on, go ahead and shoot that to me and I'll communicate that to Dan, who's been very generous to go and do that for us. All right, looks like we're down to about 23 of us right now. So if there aren't any other questions, I will go ahead then and stop the recording. And thanks for coming, guys. I appreciate this. We do have a couple other classes that we're lining up for next month, so stay tuned. I'll send out an email shortly on the details for those as well. And I look forward to seeing you. Thanks again for coming.